Thank you, Madam Chair. Thank you, Ranking Member Burr. This hearing is so very important. I really want to thank all of the witnesses here for testifying today. Your continued work, thank you so much as we combat this pandemic in real time, And so first, I just do want to echo the concerns my colleagues have raised about access to testing, both in-person PCR tests and the at-home rapid tests. We do know that home test kits are scarce. Americans are standing in extremely long lines to get a COVID test, and hospital emergency departments in my home state of Nevada have seen a significant increase in people coming solely for tests because there just aren't enough alternatives. And so this is just really only adding to the stress, as again, I can say, speak to Nevada on our health systems. Nevada's been expanding our testing options, but increased federal support on the ground in addition to home testing we feel is absolutely critical, and in the future the federal response must be more proactive in this space. And so I'm a little bit concerned about the testing keeping up with the variants, because this is all happening in real time. COVID is evolving. You don't know which strain may become the dominant strain. And so we want to ensure, just in addition to the effectiveness of the vaccines and therapeutics, that the testing accuracy must also keep up. So Dr. Fauci, with some recent reports about the current variant settling more in the throat than in the nose for some patients, what are we doing with the development and deployment of rapid at-home tests based on saliva versus a nasal swab? And then, Dr. Woodcock, how rapidly do you think the over-the-counter testing can be delivered, approved, looked at, approved, delivered to the American public to make sure that they're less anxious?
Thank you for that question, Senator. Yes, there have been recent reports that, in fact, the sensitivity and the ability to detect in a swab of the throat versus the nasopharynx, at least with Omicron. That's a preliminary report. I think it needs to be validated and verified. If the data are strong enough, then the company, whatever who makes that, will likely go to the FDA to ask to change the indication because the emergency use authorization is for a nasal swab. If the scientific data indicate that it's better to get an oral or other swab, they would present that to the FDA. So I would leave that to Dr. Woodcock to answer the rest of that question.
Thank you.
Certainly. Well, we can act very rapidly, but first I would like to say people should not use swabs that are designed as nasal swabs and try to swab their throat. They may stab themselves, okay? That would not be good, okay? What we need to do is have tests that, see whether the throat swab, as Dr. Fauci said, could provide more sensitivity. We do know the tests are picking up Omicron, but right now with less sensitivity than they did some of the other variants. As far as time, as I said, after the ITAP program does the testing at NIH, FDA has been able to authorize within a day or two of getting those data. However, the companies would have to change the test configuration to accommodate the swab, the larger swab that you'd use in the throat. That's probably what would take the most time, as well as seeing whether that was better.
And to continue with that point, as we've seen with some of the testing, the reagents or the materials that it really takes to use the test, is there the ability for people to return a test that might no longer work? Can those agents, any of that, be recycled or upcycled if they're returned to the company unopened? Like, how do we not dispose them and not get some recyclability out of that? Is that possible in some way?
We can get back to you on those parameters. Be happy to do that.
Thank you. I appreciate that. I'd like to talk a little bit again. People are talking about the public health data. We're noting about all the daily statistics. We're noting about some of the statistics about possibly death. And so positive or negative, critical, this data is critical even for us to make our decisions as far as what we fund. And sometimes there's notes to say that we shouldn't include home testing in the daily statistics because they might not be reliable. So Dr. Walensky, to build on some of that testing and the statistics that you need to do your job, that all of us need to do our job, how is the CDC working with the state, local health, our hospitals, to be sure that the voluntary self-reporting guidance it is going to be accurate and give us the kind of statistics we need going forward?
Yeah, thank you for that question, Senator. So we are routinely reporting PCR tests. That is what is routinely reported from the state, and that is what our updated statistics are. There's passive reporting that occurs with rapid tests, but I also want to understand the importance of rapid tests, at-home tests, for people to be empowered to use these rapid tests to do the right thing. So regardless of whether we can count them, generally they tend to be people who have milder symptoms. They might have been vaccinated, have a runny nose, and they decide to go and get a rapid test and do the test at home. Less important is counting that case than it is that that person stay home, isolate, do the right thing, and not be forward transmitting. So I think that many of these tests have different purposes, but one of the really important purposes of these rapid tests, even if we don't count them, is to empower the public to do the right thing through this pandemic.
Thank you.
Thank you very much.